Hello, good evening, everyone. We are very prompt this evening, ready to start. Tonight, we're going to be talking about IVF with donor eggs, and we are very lucky to be joined by leading fertility clinic in London, CRGH, Dr. Ali and Suzanne Cawood, Director of Embryology, and Dr. Ali Fertility Consultant. So welcome to you both.
Thank you.
Oh, lovely to be here.
Tonight is going to be all around IVF with donor eggs, faster recipient matching, which I'm very excited to hear more about because I know that some people are concerned about wait lists and what that means in terms of their donor choice. So the process will be part of what we're discussing tonight as well. And welcome to those who are joining. It's lovely to have you here tonight. I'm going to do some introductions and then we can get going. So as I mentioned, we are very lucky to be joined this evening by Dr. Ali, Fertility Consultant at CRGH, Deputy Medical Director at CRGH City. Welcome to you. And Suzanne Cawood, Director of Embryology at CRGH. Would you be happy just to tell us a little bit about yourselves?
Great, thank you.
Yeah.
So I've been in embryology for over 20 years. I actually started my journey at CRGH before moving to Barbados to head up a clinic there. I then came back to Harley Street before coming back to CRGH. So back to the clinic I love the most. And now we're forever growing and we're just trying to improve the service as much as we can.
After completing my training as in obstetrics and gynecology, I did a subspecialty, a clinical fellowship at UCL, research and clinical fellowship for IVF and reproductive medicine. Then I moved to be a consultant at CRGH since 2017. And I took over the egg donation program and trying to expand. We'll speak now more about it, besides, of course, offering all the fertility treatment. And since early 2023, I became the Deputy Medical Director at City CRGH.
Fantastic. Well, thank you very much for being here tonight and for your introductions. So, an introduction to CRGH, where I have had the pleasure of having some fertility testing done with you many years ago, so experienced it firsthand. Please tell us a little bit more about CRGH.
So, as you can see here, we believe that everyone should have the best possible chance. And this puts us under significant responsibility here to be able to meet this target. And we actually celebrated, just before COVID, we celebrated 10,000 deliveries, which are product of all fertility treatments, whether IVF or insemination using own eggs, or egg donation and sperm donation treatment. And we try to meet this for everyone who's keen to have to start their family, whether on their own or with a partner. And to achieve this, we have all the technology, but it's not only about technology, it's about the team behind this technology, because nowadays technology is widely available everywhere. But to have a team including from the admin team to the doctors to the embryologists, and they are all, and the quality and compliance, we all work together to achieve this. And we were one of the first clinics that did actually the genetic testing as part of the pre-implantation genetic diagnosis for those who are known to have some underlying inherited genetic conditions. And of course, we have all the types of add-on treatments, but we kind of do the approach based on more personalized way. So why we are different here when we say truly bespoke fertility treatment, whenever I assess any couple or we are a team of consultants, we take the details of the medical history, their investigations, and would like to know their target. Obviously, it's live birth, but to go through this journey, it can be different between one person and another. And it's also very crucial to be transparent when it comes to success rates and to give our advice, to take the decision together with the couple for the best chance, because sometimes There are some people when they see things online or they hear from others, they think that what's applicable to others might be applicable to them. But our role here is to give the different options and discuss it with them. Also, having 7-day service is very important here when it comes to one who needs to have an egg collection, for example, whether a donor or one having treatment themselves on a Sunday. So sometimes on a Sunday, we might have more egg collections compared to Monday. So we have full team when it comes to any day of the week. And this reflects in our success rates. We have the high success rates for that comes from this reason. So when you review the previous treatments, if someone has a previous poor or no fertilization, or the problem might be somewhere else related to the receptivity of the lining. So it's important to try to point out at what stage we need to make a difference and not use the same approach, same protocol for everyone. And in that case, you might get a good percentage to achieve a pregnancy, but there is always a group of patients, and that's the difference between one clinic and another, that you have to tweak, you have to do a little bit different approach to be able to achieve the best chance for them. And I have to admit, sometimes I tell couples, we have to draw a line at some point. Where do we stop the treatment? Where do we move to other options like the use of donor eggs, and not to keep investing in a certain treatment when it's obvious that the chances are almost nil. So this all depends on all the previous history, previous treatments taken into consideration, and the results of all the tests. Doing research and audits, we are actually, as a private clinic, we actually do research. You see from our publications, it can be even comparable to university hospitals. And the reason why we do research, because we like to check for new advances, new technology, and we don't just take anything and apply it. No, actually, we try to study more on our group of patients with the characteristics, who could benefit from that, and introduce more treatments to be able to maintain our success rates. As I mentioned about technology, you need to have the right trained persons, and Suze will tell us more a little bit about the lab. And the support is throughout all the fertility journey. Different teams are involved, and of course we have dedicated counseling team. We have personalized, and in a way, one consultant takes care of all his patients or her patients. So whenever it comes to any decision, this will be reviewed by the consultant. And also we have the nursing team who will be always in touch through the portal, and we have the on-call mobile. So the support is available at any time of the day, any time of the week. And we have the admin team who will be in touch always by emails with the patients for any queries. And the embryologists will contact the couples or the patients with the update of the fertilization and the progress of the embryos, and to explain the different stages as well. So when we speak a little bit about the donor eggs, we'll move to the next slide to speak a little bit who would be using donor eggs. And obviously there is a huge demand in the UK. This is due to there is good number of donors, but there is a little bit shortage when it comes to diversity of donors of different ethnic backgrounds. And this is also raised by the HFEA. And by the way, we are blessed to have the HFEA in the UK, because it gives guidance to clinics and to couples when it comes to all the treatments. And recently, for example, we've been seeing more couples who come with secondary infertility. Even they have their first child with own eggs and own sperm, even without the need to do fertility treatment. But when it comes to a second child, we didn't see this before 7 or 8 years ago. But as one doctor experienced, I'm seeing this more and more, because they feel actually more pressure sometimes. We think that after having the first child, we can manage, but when they are growing, they might ask for a sibling, and the couple come with more pressure, and they are willing to use donor eggs, even if they haven't done this or needed this in the first time they achieve a live birth. Also, since the law has changed, single male can also start their own family using donor eggs and surrogacy, or same-sex couples. Anyone with previous or diagnosed with premature ovarian insufficiency at any age group, or having treatments with own eggs, and there are strong signs of a quality problem. Of course, this is not a decision that we make lightly to say you need donor eggs. No, it's actually after reviewing previous treatments and having clear signs in the lab that either there are no embryos forming repeatedly, or there are embryos, but there is sign that there is a failed implantation due to embryonic factor, or recurrent miscarriage also due to embryonic factor. The majority of recurrent miscarriages, actually, they don't need donor eggs, but there is a group of them who it might be reflective of an embryonic cause, and this is when one might need donor eggs. The ovarian reserve, we always see patients that focus on numbers a lot. Of course, the ovarian reserve, we check their AMH, their follicle count, but it's also the egg quality. And this is something that shows when you see the outcome of their fertility treatment. So who is the egg donor, or how do we get in touch with them? Usually we are active on social media, so they get in touch with us, keen to donate their eggs, and it is altruistic in the UK. This is the law, so they would like to help others. And I see the majority of the donors, so some of them, for example, once I saw someone who is product of a sperm donor herself, and others, they heard about a friend and they want to help others as well. So there are different reasons because the compensation is actually limited, and this is depending on the HFEA regulation. Usually when they contact us, we have a cutoff of age, which is 35 or younger, and we take their personal history, medical history, also social history. For example, if someone is known to have infertility, unfortunately, we can't accept them as donors. If someone is known to have endometriosis, clearly found by ultrasound or previous surgery, also we don't accept them as donors. Or any significant hereditary genetic condition known to run in their family, because there is a list of specific conditions, but also we ask an open question whether there is anything that run in the family also might be a contraindication to donate their eggs. And we start by doing some eligibility screening tests that includes virology, sexually transmitted disease, and some genetic testing. And also we refer them to be seen by our counselors just to assess also from the psychological point of view. And they go through the stimulation themselves through 9 or 10 days of injections, followed by egg collection. And of course, they fill the characteristics, their own characteristics. And besides, they sometimes leave a goodwill message that can be also given to the child as a product of this future donation. So there is a very meticulous process where every donor goes through. And since the regulation has changed recently, we have to quarantine any embryos created, either eggs or embryos created from donor eggs. It means after the donation process, we repeat their screening tests few months after, actually 3 months. And this helps us to be able to make sure that there is no infection risk at all to the recipient. So when this protocol is followed, we know that we are giving the best chance for all our recipients. Yeah. So one of the challenges is, first of all, I have to admit, to make the decision to use donor eggs. This by itself is a very challenging decision. And I have to admit, people sometimes feel that they failed. But I don't want anyone to think like this. At some point, when the professional discuss with them the use of donor eggs, they feel that there's something that I could do, or many of the times these things are genetically programmed. It's not something that you could have done differently to change this outcome. And nowadays we are starting our families relatively late compared to our parents or grandparents. That's why there is more and more demand for donor eggs. So to be matched with a donor, to be on the waiting list, also it takes time when we ask to fill the form. So it could be, and this is clearly also a concern. Even the HFEA repeatedly spoke about this. Some ethnic backgrounds, unfortunately, there might not be a match, and they decide to change a little bit the characteristics to make it more feasible to find them a donor. Or some of them, they choose the option of a known donor, like a friend or a sister or a cousin. In that case, when they approach us with a known donor, of course, there's no waiting time. But for the others, here we have actually a big egg donation program as CRGH and the Ovemia Bank that we'll speak about. But because the demand is higher, that's why the waiting time is becoming more. By doing this approach, we are making this waiting time much less. And some couples, they go abroad and always get asked, do you recommend any clinic abroad? I can't recommend actually, because we don't know how's the law there, what's the screening pattern like, and also the approach, because although here it could be a case of unknown donation, but it's known to us, it's known to the HFEA. So in the longer term, we have enough data to follow up, and also this information will be available, especially that nowadays the law is changing, or is expected to change very soon, to remove anonymity completely or unknown donation. So now there is a generation of children product of donation who will get access to the donors, because this has changed about 18 years ago. So matching donors with matching egg recipients with donors. When we ask the recipient to fill the characteristics form, we have our bank where our intention is always to match with fresh egg donor, and we'll come to this a little bit to avoid any confusion, because we have a bank, but these are donors who are coming. Some of them, they donate more than one time, and we do our best to match as quickly as possible. Recently, our collaboration with the Ovemia Egg Bank makes this more possible to reduce the waiting time significantly. And other donors, we might be able to match them with our own CRGH Egg Bank. So through this partnership, we have a great supply, and the same process that I explained about having or procuring a donor is the same that applies to any donor from Ovemia Bank in terms of medical history, screening, counseling, compensation. All follows the same pattern for CRGH protocol and, of course, the HFEA regulation. That's where we are very reassured when it comes, and we are seeing now the embryos created. We are very happy so far with the outcome. It took us a long time, and Suze will tell us in the next few slides, to decide to use, because every month I receive at least one email from a clinic abroad. Would you like to use donor eggs from our clinic? And for years, until now, that we decided, okay, we found someone that we can follow the same protocol, to be happy to be able to say, this is now we are offering the best chance for our recipients. All the communication takes place through CRGH, but we communicate ourselves with the Ovemia Bank and Ovemia team, embryologists and doctors, to match the donor and to have later the embryo transferred to the UK. So the process is straightforward. It's just that we'll see the practicality, how it works in the next slide. When it comes to the recipient, after doing the initial consultation, we advise to have counseling, and the counseling is complimentary since they book the initial consultation. And when they feel ready, they will be sent electronically the characteristics form that they fill, and it will be available to us so that we can match them with a donor. Sometimes, when we choose the pathway, sometimes we might be able to match with one of CRGH egg donors directly in London, or to use the Ovemia Bank. So sometimes we might ask to do extra tests. We know that there are risks, for example, in pregnancy in older age group. For example, if someone is older than 45, so I might ask them to consider seeing an obstetrician to discuss these risks, or related to their medical history or a mammogram, because we don't want only to achieve a positive pregnancy test. We want to achieve a healthy ongoing live birth later. So this is when we do extra checks in some group of patients. And in others also, depending on their previous, with their own history of treatment, we might do extra tests, not only to create embryos, because sometimes you get the best embryo, but we might need to work on receptivity or doing some of the tests related to the microbiome or the immunity. And of course, this is something whenever we consider any add-on treatment, we explain the available evidence and why we are considering to do this. But for the vast majority, using donor egg created embryo by itself makes that chance high anyway. And when we match with a donor here, one very important thing that I want to explain compared to other clinics or egg banks is that we don't synchronize the creation of the embryo with the preparation of the lining. We always want to make sure that I have embryos first, we create the embryos and freeze them, then I can start my recipient on the hormonal treatment to prepare the lining. Because when it comes to synchronizing, if I say you have 10 eggs allocated, so the couple or the patient won't know the outcome until the day of the transfer. And this is very stressful. But no, I prefer the approach that we do. Create embryos. I know I have in storage 2-3 embryos. Now I'm ready to start the transfer. And we always strongly advise to have single embryo transfer. Unlike if people had previously treatment with own eggs, they might have transferred 2 embryos or so to improve their chances. But actually with donor eggs, we have very high chance. That's why we stick to single embryo transfer, one at a time, to improve that chance. So here it's just the sperm. Usually, if we're choosing the Ovemia egg bank, is frozen and sent to Finland. Of course, after doing all the necessary checks and matched with the Ovemia donor, eggs allocated, embryos are created and transferred back to London so that we can start with the transfer process. I will now hand over to my colleague, Ms. Cawood, and then hopefully we can answer any questions.
Thank you, Ali. So yes, a burning question many patients or potential patients may have is, why did we partner with Ovemia? As Dr. Ali said, we have numerous requests from many banks around the world that want to partner with us, but we need to ensure that the clinic that we partner with is maintaining CRGH standards. There are so many factors that we need to consider. And as I said, first and foremost, we want to make sure they're maintaining our success rates. In fact, we'd like to improve our success rates. We're always working on that all the time. So first things first, we had to make sure that the clinical and laboratory parameters of that clinic were excellent. So of course, we checked their success rates. I actually went on a visit to Ovemia along with our egg donor coordinator, a lady called Marta at CRGH. And we spent 2 days there. We toured around the clinic. We saw all the premises. I went into the laboratory. I checked all the equipment, the processes, the protocols. We observed theatre, and we met all the team. And I can say that I was incredibly impressed with their professionalism. And they had, most of the staff there had been there many years. They were very experienced. They were very thorough. They answered all of our questions. So we really were satisfied with the quality of the team, and like I said, the equipment and the protocols. And then secondhand, it's so important to know how donors are recruited, especially when they're not being recruited at CRGH. So I had to be reassured of the ethical, all the ethics involved. I wanted to know how they were recruiting donors. Finland has a much smaller population than the UK. I wanted to know how why are there more donors there? And are these donors fully counselled? Do they understand all the laws and regulations in the UK? And so again, I went through all of that process with them. I found out how they're recruiting. I found out the process, making sure that the donors go through not only medical questionnaires to make sure that they are being treated in a very safe way and that they are recruiting medically wise the best donors that are going to give us the best rates, but that those donors understand all the laws of the UK, that they'll be on an open IV register and the implications that may have for them and their families in the future. And everything that we asked was answered in an incredibly good way. Actually, the regulations in Finland are very similar to the UK. Actually, it's quite a heavily regulated country. So there weren't too many things that they had to do in addition to comply with us. It was mainly just the consent forms. They were already doing all the counselling and most of the screening So that was why that we chose Avumia. Essentially, they just met all of our requirements, and we were really satisfied with everything there. So the next thing I want to talk about is just the blastocyst guarantee program that we offer with Avumia. So most patients who are going to have to be choosing an egg donor will have probably been through IVF themselves, or understand the process to a certain degree. And as we know, I like to call it the sort of upside down pyramid within IVF. You start off with so many follicles, that reduces down to so many eggs, that reduces down to so many embryos fertilized, which then again, the number goes down when it gets to the blastocyst stage. And there's nothing more, heartbreaking than having invested energy, emotions, and finances into IVF to not even get to an embryo transfer. And this is even kind of, extra pronounced when you're an egg recipient. You, as I said, you've probably gone through this so many times before. So at CRGH, if you are an egg recipient and having treatment with us, if you don't get to the blastocyst stage, if you don't get to have a chance at a transfer, then we put you straight back to the top of the waiting list. We refer you back to Avumia, and we match you with another egg donor ASAP, completely free of charge. And you will just come through for treatment again until you get that blastocyst, so you can ensure that you have a transfer. So that's what the blastocyst guarantee is. We're partnering with Avumia, but as Ali mentioned earlier, the communication is all done through CRGH just to make it easier for you. So we're the ones at CRGH that are corresponding and liaising with Avumia, and you're just corresponding with us. So of course, we're not, the actual egg donor is recruited in Finland, and she actually goes through her treatment in Finland. So we're not, I'm afraid, going to fly all the men over to produce their sample in Finland. What we will do is they will come to CRGH anytime they want between Monday and Friday, produce a sperm sample, and then we will ship that sperm sample to Finland. So these transports are going to happen very regularly, on at least a monthly basis, because we're going to have sperm going over to Finland, and we're going to have embryos coming back so that we can perform the transfer at CRGH. So it's as I said, it's a very easy process where the man will just come, he'll produce his sample, we'll freeze it at CRGH, and it'll be kept safely for them. And we'll only send as much sperm over as is needed for the cycle, so they can be rest assured there won't be their samples being stored in Finland unless it's because we know they're going to have treatment. Is this sperm indeed transported to Finland? And then how are these blastocysts transported back? So it may seem a bit of a scary prospect, moving your incredibly precious samples between countries, but rest assured, this is actually something that's incredibly commonplace in the world of IVF now as people move across the country or even across the globe. They can't be expected to go ahead with more treatment if they've got embryos from back where they used to live. So this is something, as I said, that's become incredibly commonplace and is incredibly safe. So CRGH actually have their own in-house specialized courier company. So it's not like DHL where you just put something in the post. We do have to have a very specialized container which maintains the incredibly cold temperatures that we need to keep the sample safe. So we have a shipper primed with liquid nitrogen, keeping the temperature at minus 196 degrees Celsius. So these essentially are just a very small version of the cryo-dewars that samples are kept in every IVF lab in the world. Now it is much smaller, so the temperature is generally only kept for around 5 to 10 days, but of course the trip will be done within the day. So absolutely, we know that it's absolutely safe. It's constantly alarmed, and most importantly, the courier stays with that shipper, stays with your sample at all times. They literally have it with them. They don't let go of it. They get on the plane. It is their hand luggage, so they keep it incredibly safe. So we do all of that for you again. And we are going to be keeping your sperm sample safe, taking them to Finland, and then bringing the embryos back. So the all-important question, what's the success rates? So this partnership with Avumia has only just started. So I visited Avumia. So we started looking into the clinic last year, and then I visited them in January. I was incredibly happy with their processes, but it has taken around 8-9 months just to get all the paperwork, do all the auditing, get everything in line with the HVA so that we know we can go forward. So our first patients weren't coming through until September. So this figure here is just based on historical CRGH success rates. Of course, the most important success rate to look at is live birth as well, because you've got your pregnancy rates, you've got your clinical pregnancy rates, but what we want to know is your healthy take-home baby rate. So as you can see here, for patients aged 44 and over, so this is our success rates from 2021, which may seem like a long time ago, but this is the latest live birth data available because somebody you know, if you look at 2022, somebody that gave birth in December, you know, if they had treatment in December 2022, they'll only have given birth a month or two ago. And believe it or not, they don't contact us straight away to let us know. So it does take us time to collate all the data. But for 2021, over half, well, just under half of embryos that went back became a healthy baby, which is an incredible statistic. And if you look at that compared to the national average, it was around just over 14%. So I think the next slide has some more statistics as well. So this statistic is just for all ages. So the previous slide was for patients aged 44 and over, and 47%, so just 1.5% lower, is for every single patient we had. So you may wonder why there's not a huge difference, because obviously we know that as you get older, the success rates get lower. But with using donor eggs, that shouldn't really be the case. Because the reason success rates go down as we women get older is because, sadly, our eggs are diminishing and the kind of genetic normality of our eggs decreases. But with egg donors, we know that they're under 35, so that the health of their eggs should be excellent. So whether you're putting an embryo back in a 35-year-old or a 45-year-old, there shouldn't be too much variation in the success rate. So that's why we don't have a huge difference there. So a really, really important question. And the main reason that we've actually started using Ovumia is there is a scarcity of donor eggs in the UK. And as such, patients can be waiting months and months, maybe even a year plus, to actually get matched, which is so frustrating. I mean, people who know they need IVF just want to get on with it as soon as possible. So that's why we've partnered with Ovumia. They have they seem to have a really, really good number of egg donors willing to come through, which is fantastic. And I don't think I touched upon it really that much earlier as to why do they have so many more donors. The reason being is they just seem to have a much more transparent and a really healthy attitude to infertility in Finland, and people just really are desperate to help. The clinic we visited in Finland is very close to a university, and they do a lot of recruitment there for the university students. So they're highly educated donors who really do understand everything. But it really seems to be in Finland, they just see it almost like blood donation. It really isn't a huge deal to them, as it were. I mean, they are fully counseled. They know the implications. They know it's providing, you know, donor gametes. They know they're going to be on identity register. And obviously the process is a lot more difficult than donating blood, but that is how they seem to view it. So there are just many more young women who are very open to coming through and donating, which is fantastic. So because of this, because there are so many more donors in Finland, at the moment, we don't really have much of a wait. So the donors that have come through, the recipients that have come through to us so far have taken less than 2 weeks to be matched to a donor, which is absolutely fantastic. I obviously want to manage expectations for anyone that were to come through. And if we suddenly got flooded with lots and lots of people who wanted to become recipients, that may well increase, but I wouldn't expect it to increase much more than to 4 to 6 weeks, because there really are a very large number of donors. So that's really, really great. CRGH has many pathways to match egg recipients with egg donors, but this latest pathway using Finland is really shortening the time. It's really decreasing our waiting lists, and we've really got excellent success rates and a really good program so far. As I said, even though the treatment is happening in Finland, all the communication is with CRGH. We have a dedicated donor liaison person called Marta, who is absolutely fantastic. You have dedicated lab staff, you have a dedicated consultant. So you have this specialized team within CRGH ready to answer your questions anytime. And as Ali said right at the beginning, CRGH believes in every person having the ability to have a family. And that's just what we're trying to do.
Fantastic. Thank you both so much. That was really informative. I can see questions coming through, some of which we've touched on, but might want to go over again. I've put the slide up on the screen for people to get in touch with CRGH to hear more about this partnership and how they can look into egg donation through CRGH. And also CRGH offer free mini consultations, which is an incredible opportunity. So please do head to the website just listed there to get in touch with the team who can get you started with the very next steps. So may I ask you a couple of questions that have come in, and we'll also go on to questions people are asked in advance. The first question is around live birth rates for over 40s, but you've answered that. So if this person would like to know anything else, please do message us now. Feel free to book a consultation and the team will help you.
I just want, sorry to interrupt, I just want to mention this. They can check our website, the success rate. Now, if they Google it, will show directly and to even show the number for each age group. See more data. It's all available online. And this is verified by HFEA.
Okay, great.
And
Thank you.
Just email the clinic directly and we can give them the whole breakdown as well from the lab.
Fantastic. Then there's a question about anonymous donors. You were mentioning how you think this is going to change in the future. What are the options with the donors in Finland currently?
I'm not sure what you mean by what are the options. I mean, so when we say anonymous,
yeah, exactly. If you wouldn't mind explaining further.
There is no such thing as anonymous donation. In the UK, all donors have to be ID released. So I think there's sometimes a bit of confusion between anonymous and unknown. So obviously you're not going to know these donors yourself, but the donors have agreed to be ID released, and their identifying characteristics, that's their, their name, their passport details, their address, their phone numbers, all their contact information to be kept on the UK HFEA register, so that if the child that's born as a result of their donation wants to find out who this person is in the future, they can contact the HFEA and find that information out. And obviously the donor themselves are aware of this. The recipients can't find out that information. So the recipients just get non-identifying information about the donors. So, their physical characteristics. They also write sort of short pen messages, their profession, things like that. But they're not anonymous. The children can find out about these donors. Does that answer the question?
I believe so, but please say if it doesn't. Because I have sperm donor conceived children, so I've been through the donor selection process. What about seeing pictures of the donor as a child, things like that? Is that a possibility?
Not in the UK. Yeah, sometimes you see this abroad in other, like the US, some states, but not in the UK. And here to mention that they have access to the characteristics, but the child will have the right to know identifying details of the donor. Even let's assume this was not disclosed by the parents that they are product of donation. We know nowadays there is the ancestry testing widely available. You can order a kit that you receive at home and people will know where they come from. And this is also important. If two partners in the future meet, if they know that they are product of donation, they can do a joint application to the HFEA to see if they came from the same donor, even if they are not keen to know who's the donor. So this is why this regulation is meant to make things more known for the future and more protective. And the maximum number of families created from one donor is 10 families. But I have to admit, we rarely meet and reach this number from egg donors. It's easily reached for sperm donors because the process is much easier, but not from egg donors, because from one cycle of egg donation, we get maybe one or maximum two, even if they do this.
It's lower, so we can't even create that number anyway. But no, unfortunately, even childhood photos is a no, Eloise, because that is identifying. So no one in the UK should be able to access that information.
Because it's going by UK laws, because the treatment's happening in the UK.
Exactly, yeah.
We've had some other questions about what you can find out about the donor. So what about physical traits, education, hobbies, things like that are non-identifying?
This will be disclosed as much as the donor discloses this. So we can't ask the donor so we ask them to fill a form that includes all these. Some of them, they are very generous. They write a lot about it. And others, they are very brief. So, but there are some requirements that we have to fulfill, including the characteristics and the medical history and the family history, at least. Yeah.
Mm-hmm. Mm-hmm. We've also had a question about donors from ethnic backgrounds, so Black, South Asian, for example. You mentioned that there were limited options in the UK. How has it changed?
In Ovemia, obviously in London, we are a city with lots of diversity. In Finland, it's less diverse, I have to admit, but this is the challenge for some ethnic backgrounds. It's always a challenge because it's a little bit related to different factors why there's not much available donors from specific ethnic backgrounds reported in the question. But whenever we have, usually we directly match them because we have people on the waiting list already from specific ethnic background, so they will be prioritized whenever we have a donor. But their availability is not like other donors of most commonly donated ethnicity.
And someone has said that they are on the waiting list at CRGH for egg donation, have been this year. How do they find out more about it? Is it something that you talk to your
I think
patients?
she mentioned the month, and at that time we did not have Ovemia yet. So this started from June, July to match them. So this is why, but we are actually in the process of contacting everyone. So I want her please to write to her consultant. I'm sure she has the administration, or we can be in touch with her just to review the file, see a little bit more about the details. Sometimes, and here this is mentioned briefly during the presentation, I ask sometimes couples whether they are okay to have a little bit more flexibility in their characteristics. Of course, at the end, we respect if they have specific eye color, hair color. This is how it works to match them. But if someone is more flexible, it makes the waiting time definitely less. But if she can please write to her consultant or give the details later, so that we can, of course, do our best to match. And if Ovemia hasn't been offered, we try to see if we match fulfill the matching process.
Brilliant, thank you. This is a great question, which we haven't covered yet. What happens if a couple has male factor issues as well? So,
Suze, would you like to answer this one? Yeah.
Yeah, absolutely. So it depends how severe the male factor issues are. So we still offer a blastocyst guarantee program for sperm, as long as it's kind of 5 million sperm per mil and above. If they have a lower sperm count than this, or they even have like testicular biopsy sperm or anything like that, we can still offer them this program, but they potentially wouldn't have the blastocyst guarantee, and that's a restriction put in from Ovemia. But we can treat everybody, even with male factor.
So would the process be ICSI?
The process is ICSI for everybody, regardless of how good the sperm is, because we freeze it and send it over to Ovemia, and they want to make sure they're selecting the absolute best sperm, because obviously the eggs are so precious. So we perform ICSI for everybody.
Okay, great.
I recall a few couples, because usually not when we use donor eggs, this is the importance to know the impact of the egg on the outcome, and compared to someone using own eggs. So when it comes to the use of donor eggs, the egg can compensate a lot for the sperm. So I recall in some couples where we have only few sperm in the whole ejaculate, not millions, not even thousands, and we still manage to get a live birth because the egg can compensate a lot. Of course, we warn the couple in this specific case, be prepared. We might not have embryos, but certainly with egg donation, if there is a chance, it's the best chance by using this route.
Matching process, is it just done based on one person's opinion, as in who decides regarding the match?
So when we match, we have their characteristics and the donor characteristics. So the couple themselves, what we find matches these characteristics as much as possible. We tell them these are the characteristics of the donor. Are you happy with this match? They can either accept or decline. Because at some point we're thinking about introducing like some AI program that does the matching, but it wasn't. You need for this to have thousands of donors to be able to do this process. So we rely on matching the characteristics one by one, or the majority, and then the couple will be confirming whether they are happy with this. If they decline, we just try to match them again.
Mm-hmm. And then there's a question around success rates, how they're sort of quantified, how many couples or that's based on, to get those statistics for 40 plus patients.
So since I have this question, as I answered, it's available on our website, but just to give you an idea, in 2021, I'm speaking about this because it's verified by HFA, it's 108 cycles of transfer.
It's 108 patients.
108 patients. And in the age group 40 to 42, it was 23 patients, 43, 44, 29 patients, older than 44, 31 patients. And there is the percentage of success for each age group. So they can, they can calculate either age group or all of them. So in total, we have 54 live births out of 108 patients transfers, and 47% was the success rate. It's all available on the website. If they click more data, it will show them more than the percentage. It will show them the for each age group, the number of cycles and the live births.
Really
I've
useful
seen
to
that
know.
question, and you know, I kind of feel for that patient because you want to know the actual figures, and I understand when clinics are reluctant to give the answers. The only thing is that I would say to that person is that I would hope clinics aren't trying to hide their rates, but sometimes, and especially with egg donation treatment, most clinics treat very few patients because of the scarcity of egg donors. So they've probably only treated 5 or 10 patients, say, and so therefore it's really difficult to come up with a percentage because, you know, obviously just 1 or 2 patients not getting pregnant or getting pregnant changes the statistics so hugely. But at CRGH, we have performed a lot of these treatments, so our percentages are very steady and reliable.
Really useful to know. Thank you very much. Is there anything else that you want to touch on before we end this evening, based on what people have sent in?
I think I just want to add that we started looking for other source of donor eggs to be able to meet our patients' demand and to give them more options. And when it comes to the embryo transfer and chances of success, most of the time you do the simple approach of an embryo transfer cycle, but we have all the available. This needs another wide discussion of any treatments related to receptivity or improving the chances, and doing the right approach depending on the age group. So all of this is available, and we discuss it. We take a decision together with the couple or with the patient herself to decide which one of these approaches or add-on treatments to do before proceeding with the transfer, or shall we just do it the direct embryo transfer process. Doing the extra tests related to age group, checking for any medical problems to have a safe pregnancy is very important as well. We have lots of patients actually who are 48, 49. So here you want to maximize their chance and not to end up in a high risk pregnancy. So by doing these necessary checks, not only to have good embryos, but to have a healthy pregnancy as much as possible.
Yeah, absolutely. I think it's a very exciting partnership that you have, because it opens up so many opportunities for people who, as you said, may not have found their match as yet. And, you know, it gives people the opportunity to explore other donations and speed up the process. So thank you very much for taking us through everything this evening. I found it very, very insightful, and would suggest that people go to the CRGH website to find out more, and also book a mini consultation to discuss your personalized treatment plan with a specialist, so that you can find out what the best route would be for you. So thank you very much, both of you, for your time this evening. It was fascinating and lovely to be connected with you doing this webinar today.
Great. Thank you so much for inviting us.
Thank you, everyone, for joining. Have a good evening. Bye-bye.
Bye.